I thought that since y'all work mostly in the psychiatry department, that we talk a little more about delirium. So I don't know how helpful this will be for you. Hopefully it will be. And again, any stories that you've got, I would love to hear as well. The DSM-4 defines delirium as meeting 4 criteria. Number 1, acute onset. So something that happens very suddenly. It usually waxes and wanes, and more times than not, in older patients, you'll see it at night. It's a phenomenon that people sometimes refer to as sundowning. But sundowning doesn't always mean delirium. Sundowning can happen in dementia, which is very different from delirium, or somewhat different from delirium. But qualification number 1 is it has to have acute onset. Number 2 is there's a change in the level of consciousness. So if somebody is normally a very sort of manic, pressured speech person, and then all of a sudden they're very calm and it's not really medication related, or they're very out of it, or somebody who's normally very sweet and cooperative and then all of a sudden they're, taking punches at the nurses, then that's a change in consciousness. When you can't tell, sometimes if you just think in the back of your head, I think, okay, this person can't pay attention. If you think about it, if someone's really sleepy, it's really hard to pay attention, and if they're very hyper, it's also hard to pay attention. So that's the way that I like to define a change in level of consciousness. Does that make sense? And then it's also associated with some cognitive impairment. So you need to know what the patient's baseline mental status is and cognitive function is, which you can ask families. They're usually pretty forthcoming about it. So it's some impairment in their cognition. And it's always associated with a medical comorbidity. It's rarely associated with one comorbidity, but it's always associated with something. And you can always find something. The 3 different kinds of delirium, when we think of delirium, this is the one that everybody thinks of. It's because the squeaky wheel gets the grease. The patient who's screaming and yelling and punching people is the one who gets the attention. So hyperactive delirium is the one we think of most often. However, there's some people who theorize that hypoactive delirium is actually more common. And these are the people who, they're not really responsive, they're sort of sleepy, and they're normally not like that. They're just kind of laying in bed and not cooperating, not paying attention. And because this is under-recognized, it's thought to be associated with the worst prognosis. There is an estimated 65% morbidity associated with delirium. That's pretty high, and the mortality rates are in the 30s. That is, it's probably not a direct result of delirium, but what happens after you become delirious.
I think we had
a... Oh, sure. Sure.
How does that relate to catatonia? When a patient's catatonic?
So patients who are catatonic could meet the criteria for delirium.
They probably don't do the waxy arm thing.
Yeah, I can't think of a situation where somebody is just sort of always born catatonic and always catatonic. So patients, if they're catatonic, it would have an acute onset because at one point they became acutely catatonic. They did have a change in their level of consciousness. We can go back to that side. A change in their level of consciousness, right? Because they're cognitively impaired because they can't do a mental exam of any kind. And it's probably associated with some comorbidities. So in their case, maybe a trauma that happened that made them catatonic, which I think is usually the case, right? When patients become acutely catatonic, something's happened to them, they've seen it.
They stop their meds.
Yeah, or they stop their meds.
So what I was going to say, I think, boy, I wish our ER doctors were hearing this because they seem to put these people on 5150s that, I mean, we
really?
Remember that old lady in 307 that her husband was here all the time?
Yeah.
She was delirious. She got moved finally after about 5 days of hitting us and screaming and carrying on and having to pee every 2 seconds, but she really didn't have to pee. I mean, she met all these things. And
did she have another medical condition? Did she a urinary tract infection or something?
She had a history of bipolar, but which it could have been, but it seemed like she fit all these and she did get moved to medicine and never came back. So
I see.
my assumption is, we can't check afterwards, you know, but
Right.
my assumption is that she was.
Delirious.
Do you see a lot of that at CPMC later?
Well, it's easy. I'm trying to be political
I'm
here.
sorry.
No. I'll
Do
just
see
tell
a
you.
lot of that?
I
will
do.
say at CPMC.
We see it on a daily basis for sure. And I think that everybody has somebody on their service that's delirious and maybe has been mistriaged. Is that a proper way to say it?
Do you see?
So, again, trying to be political, the medicine service is very welcoming. In other words, we very rarely refuse a patient. So we are the ones who are called first. Let's say that. Well, okay. So when other services aren't interested in taking the patient, they come to medicine. Is that fair?
Yeah,
So yeah,
no,
we
ours
do.
just get put on 5150s,
Yeah.
and it seems like
I hear a lot of,
delirious.
I'm actually very encouraged to hear that you do see geriatric patients, because we get a lot of, well, we don't have a geropsych cord, so we can't take the patient.
That's why you're here.
Because you're turning into a geropsych ward. So it's true.
But the
No.
concern, I think, sometimes that people are considered a psych patient. Like, she had a history of bipolar, therefore
Right.
she must be a psych patient. When actually, I don't think she was eating much, and she was probably dehydrated. No, elderly patients before have been rehydrated, and their medication changes remarkably in a very short period of time, because they're suddenly, oh, hello, yeah, I'm hungry for dinner now. Before they're like,
That's an
You know, and
excellent
it's
point.
a remarkable change with, a little bit of fluid.
No, that's an excellent point. In fact, dehydration is a huge risk factor for delirium. And it does happen in older patients, and that's part of the homeostenosis, is that, and actually this has to do with osmostats, how people perceive thirst. So, for instance, right now, I haven't had any water in a couple hours. I'm starting to get a little thirsty. My body knows that. Now, 15 years down the road, my body's not going to be as sensitive to that. And that's natural. That's a natural change, okay? But when you get older and you're really not sensitive to it, and someone's not following you around saying you need to drink more water, you need to eat more, you will get dehydrated. You're going to get admitted to the hospital, and a very common way that these people present is delirium.
Do you want some water? I'll get
No, I'm fine, thank you, though. I was just trying to make a point. No, I'm fine. But yes, you're absolutely right. So triaging these patients is very, very difficult, and it's because it's hard to communicate with them. It's hard to get a history from them, exactly what's happening, And you said her husband was here a lot, and despite what I'm sure are his best intentions, you get caught up in the emotions of taking care of your wife, taking care of your loved one, and you're not really giving a good medical picture, and then the patient's triaged maybe inappropriately. Although I'm sure she got great care here, but
So how can we better, if we have an elderly patient, how are we going to know if she's in a manic state sometimes, if she's not, because if she's had an H&P and this kind of stuff, and nobody's really looking at her possibly as an elderly person with physiological.
of course,
deficits
that is,
and problems.
that's,
It's difficult for us to.
no, it is. That's really hard to say. My approach personally would be to look for the easiest things to correct. So you look for, and the things that don't require as much diagnostic testing. So you look for dehydration, you look for infection, and you look for any changes in medications. Those are probably the ones you can do with the least amount of testing, least amount of blood draws, et cetera. It's easy enough to get a urine sample. It's easy enough to, oh gosh, yeah.
And this lady was having lithium problems with her kidneys, of course. She'd been on lithium forever, so they had taken her off.
And people always assume that, well, people make a lot of mistakes in terms of a situation like that. Well, she's been on lithium since she was 30 years old. She's been on this dose. Why would we change it now? Because her kidneys are changed, they're not processing as well. Or, oh, she's fine. Why don't we just take it off? Withdrawal, it happens, right?